So yesterday I started by giving the foundation, okay, of diabetes. Please, can you all hear me?
Yes, please, we can.
Yes, we can hear.
Sometimes
Yes,
it was breaking, but it's better.
sometimes it breaks.
Oh, okay. It will be fine. Okay, all right. So I started the foundation yesterday that anytime you eat, the moment you finish eating, right, there is an increase in your sugar level. Okay, there's an increase in the sugar level in your blood. So there must be the release of what? Of insulin by the beta cells in the pancreas. Then this insulin will have to shift the glucose from the blood into the cells for energy, right? So that is what occurs basically after eating. But then if you are that type that has an issue with your pancreas, right? So there are no insulin production from the beta cells in the pancreas, or for whatever reason there is resistance. Okay, there's resistance to the insulin after being produced by the beta cells. It means that the insulin cannot work effectively by pushing what? By pushing the glucose from the blood into the cells, and this can contribute to what? Can contribute to diabetes mellitus. Then I made mention of the fact that when you are fasting, usually there must be a release of glucagon by the alpha cells. This will help what? Increase the sugar level when you are fasting and you are not eating. And then I said that this one usually works the more at night. Okay, when you are sleeping and you're not eating, I mean, yeah, you are. It looks like, or it's assumed that you are fasting, right? So that is when the glucagon comes in to do what? Increase your sugar level. Okay, so yesterday we established that fact. Okay, very good. So today, probably you might end it today. Okay, very good. So diabetes mellitus, as you can all see on my screen, is a chronic metabolic disorder. Okay, characterized by high blood glucose levels due to impaired insulin secretion, insulin resistance, or both. So it is either there's something wrong with the insulin secretion, or there is something. I mean, the insulin is being released, all right, but then there's a resistance to the insulin, or there is both of them. Then we say what? There is what? Diabetes mellitus. Very good. All right. So we have types of the diabetes. Okay, we have types of diabetes. We have one, a type 1 diabetes. And then the other name for type 1 diabetes is what? Insulin dependent. Okay. Insulin dependent. Because these people, those who suffer from type 1 diabetes, usually they are children. Okay, they are children. But one thing you should know is that these people usually they don't produce the insulin at all. Okay, they don't produce the insulin at all. There is something wrong with their beta cells, and then usually it's an autoimmune distraction. When when the immune system fights the body and releases antibodies that destroys the beta cells in the pancreas, then there will be no production of insulin at all. Okay, so these people, because they don't produce the insulin at all, they are called insulin dependent, or type 1 or diabetes. Okay, so let's take note. Then the type 2 is called the insulin resistance, okay, or impaired insulin secretion. So these people too, there is production of the insulin, all right, too. Okay, insulin is being produced, all right. The type 2, the insulin is being produced, all right. But then for whatever reason, like obesity, like physical inactivity, okay, this is stopping the insulin from having its full course. They will be released, all right, by the beta cells in the pancreas, but then they are meeting some kind of resistance. You get it? So because of that resistance, the insulin cannot work effectively to push the glucose from the blood into the cells, and then they leave the glucose in the blood, and can also be a factor for what? For diabetes mellitus. Then we made mention of the fact that there's also what? Gestational diabetes. Okay, there's also gestational diabetes that occurs when you are pregnant, right? Good. So we have causes and risk factors for what? Diabetes mellitus. So one, we have genetics or family history. When I think yesterday we even spoke about this, right? When your parents do have diabetes mellitus, right? Or your sisters or your brothers, the first line family risk factors that I made mention of yesterday, when they have it, it's believed that it can be transferred to you, okay, genetically, right? So that one, we believe that it's a family thing. Okay, it's a family thing. So when a mother has it, when the father has it, it can be transferred to other offsprings from the parents. Okay, or maybe if it's in the family, it runs through. So that is also one risk factor. Okay, it's just belonging to a mother or a father who has diabetes even predisposes you, or it becomes a great risk factor for also getting diabetes. So let's take note. Okay. Then 2, obesity. Now, how does obesity contribute to, or how does obesity predispose you to getting diabetes? Okay. So when you are obese, obviously we all know that obesity comes with what? Fat. So when you are obese or when you are fat, okay, there's a high level of what? Fatty acids or fat deposits in your body or in your system or in your tissues. Okay. So when a person is obese or someone is fat, the production of these fatty acids, okay, or fat deposits can be released into the bloodstream and then can hinder how insulin must work effectively. Okay, so fatty acids and fat deposits play a major role by hindering insulin, okay, from pushing glucose from the blood into the cells. You get it? So obesity is also one of the major risk factors to diabetes mellitus, right? Because of the production of fatty acid that become a resistance. Okay, so the fatty acid tends to become like an obstacle that stops the insulin from pushing the glucose from the blood into what? The cells, right? Then we have 3, physical inactivity. That is lack of exercise. Someone who's bedridden, does not perform any serious exercises, okay, that person too is at risk for getting diabetes. Do you know one thing? If you exercise a lot, the more you exercise, the more you increase your body's sensitivity to insulin uptake. Okay, the more you exercise, the more you increase the body's sensitivity to insulin. So if you don't exercise, insulin will be released rather, but the body will not be sensitive to it. Because anytime your body is sensitive to this, that is when the insulin begins to work effectively. Okay. If you realize that insulin is working effectively, simply means that you are exercising well and your body is pretty sensitive to the insulin. And then exercise is one of the factors that helps the body becoming sensitive to insulin. So someone who doesn't exercise, always in bed, does not engage in any physical activity, that person renders the body inactive or insensitive to what? To the insulin uptake. So the insulin will be released all right by the pancreas, right? But then the sensitivity will not be there for the insulin to function. Okay, very good. So that is something that we should also know. Then we have pancreatitis. This one is obvious. The cells that regulate insulin or the cells that regulate the sugar are from the pancreas. We have the alpha cells, the beta cells. All these are being produced what? By the pancreas. Okay, so the beta cells produce the insulin, and then the alpha cells produce the glucagon. All these two helps in the regulation of what? Regulation of sugar. So if you have pancreatitis, whereby there's an inflammation, okay, there is an inflammation of what? Of the pancreas. So pancreatic ducts are being blocked. There's no release of what? Of these enzymes to help, and then they digest inside the pancreas. It can affect the cells in it. Okay, when the cells have been affected, insulin will not be produced effectively. Or let me say, the alpha cells and the beta cells that should be produced by the pancreas for their effectiveness will not be achieved because of the inflammation. Is someone speaking, please? All right. Please, can you hear me?
Yes, please, we can.
Hello.
Please, we can.
Okay. All right. All right. So that is fine. So that is why pancreatitis is also a risk factor. Now, when we talk about pancreatitis, then we should think about what? Alcohol. Okay. We should think about alcohol. You know, one of the major risk factor for pancreatitis is what? Alcohol consumption. So we should think about alcohol as well. Okay, then we have aging, and that is the risk increases after being 45 and above. No, just when you begin to age, okay, you begin to turn 45 and above, 50 years, 55, that one alone just predisposes you to getting diabetes. Okay, you know, aging comes with a lot of degeneration. Okay, how the body should, I mean, be take up the insulin is not active or has been reduced because of a lot of degeneration in the cells, a lot of degeneration in your body. Okay, so even how the body will have to respond to the insulin after it has been released becomes a problem. Okay, so aging also put you at risk for getting diabetes. Then we have ethnicity. This one, just become an African. I mean, Black American, or let me say African Americans, okay, or Hispanics, okay, Black American, African Americans, or Hispanics. Just that alone put you at risk for getting diabetes mellitus. We have 7, history of gestational diabetes. Okay, history of gestational diabetes. So a mother who had a previous gestational diabetes stands a higher risk of getting diabetes mellitus. Okay, so you had the situation or you had a condition when you were your first pregnancy, there was gestational diabetes. Okay, going forward in your next pregnancies, okay, or in the pregnancy to come, you're likely to generate diabetes mellitus because of the previous one. Okay, very good. Then the last one, we have certain medications like steroids or psychiatric medications. Okay, so we all know we did what Cushing syndrome, right? Very good. We did Cushing syndrome, and then we established that steroids. Okay, steroids has a way of promoting glucogenesis. Okay, that is synthesis of glucose, right? Steroids play a major role in the synthesis of glucose. Okay, so when you take steroids for a longer period of time, for example, a patient with Addison's disease, okay, if you have Addison's disease, it means that you have low steroids level. So this patient will be put on steroids for life. So this patient, obviously, at the long run, they will suffer from diabetes mellitus, okay, because we are going to take the steroids for life. And because of this, the patient can get diabetes mellitus because steroids contribute to what? Glucogenesis. That is the synthesis of glucose. Okay, very good. Then we have certain medications like psychiatry one, haloperidol, olanzapine, okay, clozapine, those kind of drugs. The atypical antipsychotics. Okay, they are very good in promoting diabetes. Okay, they help, or let me say, they are risk factor. The moment you start taking haloperidol, okay, you start taking clozapine, olanzapine, those kind of drugs. The atypical, what do you call it? Atypical antipsychotics. It causes a resistance. That one, to do know what it does. The psychiatric drugs, it causes what do you call it? Resistance to insulin what effectiveness. Okay, the moment you start taking, let's say, haloperidol, for example, it has a way of causing or let me say being an obstacle to how insulin will function properly. So the insulin will be released all right too, but because you've taken this drug for long, it will have a way of stopping the effectiveness of the insulin by becoming a resistance to it, and therefore contributing to what? To insulin or diabetes mellitus. I mean, it contributes to allowing the glucose levels becoming more in your blood. Okay, and therefore we have diabetes what? Mellitus. Okay, all right, very good. So someone has answered the question. Okay, so Hispanics are Latin American origins. Okay, so you can read about them. Okay, you can read about the Hispanics. Okay, you can just try and read about the Hispanics to know about them. Okay, all right. So these are the major risk factors for getting diabetes mellitus. All right. Very good. Now the signs and symptoms of diabetes mellitus. Okay. In type 1 diabetes and in type 2 diabetes, their symptoms are, let me say, the same. Okay. They are just the same. Okay. We are almost having the same thing when it comes to type 1 diabetes and type 2 diabetes. Okay. So the major, what do you call it? Signs and symptoms are the 3 P's. Okay. Please, the signs and symptoms, we should focus on it very well. Okay. Because in case you get a question on your NCLEX, a case study, these are the major signs that will be present in the history. Okay. These are the major signs and symptoms that will be present in the history to alert you that what there is diabetes mellitus. Okay, very good. So we have one, polyuria, excessive urination. You know, the reason why there is polyuria, okay, in diabetes mellitus, that they urinate a lot, is because of the increase in the glucose level. I think I've been saying this all the time, that, you know, God created our body in such a way that, or our system is made in such a way that the moment there's something wrong somewhere, okay, there must be a compensatory mechanism. That is how the body works. Okay, there must be something that must compensate, or the brain must communicate through the nerves to the other parts of the body to compensate for whatever for whatever disease that is occurring. Okay, so please, let's note that. So when there is glucose, plenty glucose in your blood, okay, because the insulin is not being released, or the insulin is meeting resistance to push the glucose from the blood into the cells. Because of that, there have been a lot of glucose in your blood, causing hyperglycemia. Okay, now when this occurs, the body does not sit and watch what is going on. Okay, always the body tries to compensate. So the body will try to get rid of the excess glucose, and that is how the polyuria comes in. Okay, the brain will now start speaking to the kidneys. Charlie, there's a lot of glucose in the guy's blood. Why don't you get rid of some of them? Okay, so just urinate so that there will be excretion of the glucose through the urine. That is how the body tries to compensate with the hyperglycemia, okay, or the high glucose levels in the blood. Okay, so we get polyuria from diabetes because there is more glucose and the body is trying to compensate by bringing some of the glucose out in the form of excretion of urine. That is how we get the polyuria. Okay, so because there's plenty, they just urinate plenty. Let's bring the glucose out. Let's bring the so they just urinate here and there. Okay, that is how the polyuria comes about. Now, if you are urinating plenty, what occurs? You are going to do what? You are going to lose water. You are going to be dehydrated. And then if there is no water, it means that thirsty will set in. Okay. Now you start having becoming thirsty. All right. So because they urinate plenty, they become thirsty a lot because all the water in the system is going out. There is no water in the system, right? So there becomes what? Polydipsia. They will have excessive thirst because you are losing water. Right. Then we have polyphagia, excessive hunger. This one too, okay, because the glucose are in your blood. I said it yesterday that the glucose, after it has been in your blood, the insulin must come and push some from your blood into the cells. Please note that, okay? The insulin must be released by the pancreas, okay, to push the glucose, some of them from the blood into your cells, okay? Now, when the cells, the reason why the glucose are being pushed from the blood into the cells is because for energy, the glucose is being needed for energy. Okay, so you and I this morning or today, I'm sure we've all eaten. So we've been able to move and come here and there. Simply because we had energy from the glucose. So meaning we have glucose in our cells. Okay, now someone who is suffering from diabetes, this person will not have the glucose in the cells for energy. So what do you think is going to occur? Consistently, this patient feels like there's nothing in my cells for energy. My cells is being deprived of enough glucose. My cells is starving. Okay. Always the glucose must be in the cells for energy so that to the body feels okay. I'm not hungry. I have enough glucose. Okay. I'm not hungry. I have enough glucose and I'll be fine. But because the glucose is not being pushed from the blood into the cells begin to starve. They begin to what? Have limited glucose, and that one can increase the hunger. Because of that, the patient continues to eat because they need the food for energy. If you are weak, what do you think of? Oh, I am getting weak. I have to get some food to eat. Okay. So if the cells are deprived of enough glucose, the body assumes, or the body sees that there's nothing there, so I have to compensate and eat more. so that I can get the glucose in my cells. That is how they also get into what? The polyphagia or the excessive hunger. Okay. Very good. That is how the excessive hunger sets in. So these are the 3 key signs and symptoms of diabetes. At least anytime you hear of diabetes mellitus, these 3 must come into your mind. Okay. Polyuria, polydipsia, polyphagia. No, don't forget, usually we get the first 2 in what? Diabetes insipidus. Okay. In diabetes insipidus, we get polyuria and polydipsia as well. But then don't be confused on the NCLES. In the NCLES, in diabetes insipidus, there's nothing in association with what? Your glucose level. So keep that one in your mind. When you see polyuria, polydipsia, dehydration, patient drinking more water, don't start thinking of diabetes mellitus until you've watched the patient's glucose level. Okay. If you've not monitored the patient glucose level, don't start concluding that this is diabetes mellitus, because those symptoms can be associated with what? Diabetes insipidus. Okay, so when you check the patient glucose level, you realize that the pancreas are fine, there's nothing wrong with the glucose level, then you can conclude that it's diabetes insipidus. Right. Very good. So let's take note of that one too as well. Good. So these signs and symptoms are common or present. Then we can have fatigue. Obviously, this patient is starving the cells. They are bringing all the water out through urination, so they are becoming dehydrated. Won't you be fatigued? You are going to experience general weakness. Okay, so the moment you do something small, you are weak. There's fatigue. So this one is obvious. Then there's hyperglycemia. I have been explaining this all the time. Because the insulin is not pushing the glucose from the blood to the cells, there's going to be high glucose level in the blood, leading to hyperglycemia. Then there is slow healing of cuts and wounds. Okay, this one, the reason why diabetes patients they have slow healing. Okay, when it comes to wound, it's one. When you have diabetes, the glucose can sometimes form or can accumulate in the blood arteries. Okay, to some extent, when there's too much glucose, they can form and accumulate in your blood arteries, or let me say your blood vessels. Okay, when these vessels are being affected, it impedes on blood flow. Okay, through the vessels, through your arteries and your veins, because of the excessive accumulation of glucose. So when that occurs, even blood flow to areas whereby there's wound to supply oxygen so that the wound can heal early is being affected. Okay, so that is one factor as to how or as to why diabetes patients their wound does not heal faster. Okay, because there's even limited oxygenation to the area due to the accumulation of glucose, blocking the blood flow. Okay, so that is one thing that we should know with regards to the wound not healing faster. Then we have numbness, tingling in the hands and the feet. That is the neuropathy. Okay, patients who have diabetes suffer from neuropathy, whereby the nerves are being affected because excessive glucose accumulation can endanger or can affect or can destroy your nerve cells. So let's take note. Okay, excessive accumulation of glucose in your blood and in your blood vessels can later on endanger or destroy your nerve cells. So this can lead to hot, numbness, and tingling in the hands and then the feet. Then we have glucosuria. Of course, you urinate and there'll be urine, or there'll be glucose in the urine. That is why I explained earlier on, right? The body tries to compensate through the production of glucose in the urine so that they will get rid of it. So the moment you test the patient's urine, you will see the presence of what? The presence of glucose in it. Okay. Then we have ketosis. This one I explained yesterday. Okay. When you starve the cells for a longer period of time, the body does not sit down idle. Right. The moment the body has been starved for a longer period of time, it doesn't sit idle. It starts to break down stored fat and stored glycogens to be used by the body for energy. Right. So in the breakdown of stored fat by the liver, then we get what? Ketosis, or let me say ketones. Okay. This one is more prevalent in diabetes ketoacidosis. Okay. Then we get what? Ketones in the urine. So let's take note. Because the body is trying to compensate by breaking down stored fat in the liver to be used for energy, then we can get what? Ketones or ketosis. Okay, very good. Now there is 10, dehydration. Of course, you are urinating plenty. So we are going to lose water. There's going to be dehydration. Then electrolyte imbalances. Okay, electrolyte what? Imbalances. Because there is what? Excessive urination. You can even go into hypokalemia because we are urinating more of the potassium. We are just excreting more of the potassium out. We are going to get what? Hypokalemia. And then we learned something under DI and SIDH. Okay, usually when you urinate plenty, you are bringing out what? Free water. Okay, you are bringing out free water. So the body will be left with what? A lot of sodium. Okay, there's going to be also hypernatremia. Okay, there's going to be hypernatremia as well. And then you can get cardiovascular diseases. As I said, glucose, when it becomes a lot, can accumulate in your blood vessels, and then blood flow becomes what? Impeded. This will put pressure on the heart, okay, which can lead to severe cardiac arrhythmias and then cardiac. There can even be hypertension as well, okay, because the blood is trying to pump to push the blood through the blood vessels, okay. All right, so that is that for the signs and symptoms. These are some of the major signs and symptoms of what? Diabetes. Okay, very good. All right, please, are you on the same page? Are you following, please?
Yes, please.
Okay, all right. Then how do you diagnose diabetes mellitus? The diagnosis, we have one. First, that is FBS. Okay, I think you have been doing it all the time. FBS and RBS. Okay, FBS and RBS. So fasting blood sugar. So where the fasting should be 39 to 5.5. Okay. Normal FBS or fasting blood sugar or fasting plasma glucose, okay, should be 3.9 to 5.5, okay, or 70 to 90. Yesterday, I taught us how you convert from millimole to milligram per deciliter. Who can remind us?
So you're saying
Divide by
divide.
18.
Multiply by
Okay.
18, divide by 18.
Millimole per liter by 18 to get the per deciliter.
Okay. Okay. If possible, raise up your hand, okay, so that I can call you for you to speak. Okay. All right. I just wanted to pass this across. All right. So that is it. So when you are converting from millimole per liter to milligram per deciliter, you multiply by 18. And when you are converting from milligram per deciliter to millimole per liter, you divide by 18. Okay. It's as simple as that. So the normal one for FBS should be 3.9 to 5.5 or 70 to 99. Okay. 70 to 99. All right. But please, let's note, according to the US system, okay, usually they have their sugar level between 3.9 to 6.1 millimole per liter. Let's take note. At least should be within this range, okay, 3.9 to 6.1. Even for both random and then random and then FBS, it should be between this range, okay, usually 3.9 to 6.1. That is 70 to 110 milligram per deciliter. Okay, 70 to 110 milligram per deciliter. All right, that is fine. Now we can also do what we call the oral glucose tolerance test. This one, usually we do it pregnant, or we do it for pregnant women. We do this one for pregnant women, or we do this one usually in pregnancies. Okay, that is if you want to diagnose gestational diabetes. That is when usually we do this one. Okay, now how do they do the oral glucose tolerance test? It's simple. Okay, it's simple. So we have first of all the 1 hour, please, it is not everything that it is being placed on the slide, because this is a PowerPoint. Okay, it is a PowerPoint, so it must be well arranged. I mean, it shouldn't be packed. It should be simple and clear, so most of the things that we explain comes from what of the things that we must learn also comes from the thing that we explain. Okay, so let's take note. Some of the things that you explain, you must pay attention to them, right? Very good. Don't be glued to the slides alone. Okay. So now, how do we go about the 1 hour glucose challenge test? Okay. The 1 hour glucose challenge test. So this one, it is performed anytime of the day. Okay.
Please, you are breaking.
Perform any time of the day, and does not require any fasting. The one who challenge. Okay, I'm breaking. Can you hear me? Hello, hello. Can you hear me?
Please,
Hello, please. Can you
Yes,
hear
you
me?
take it
I can
again.
hear you. Your line was
Exactly.
breaking.
You take
Okay.
it again.
Okay. All right. All right. So I was saying that the 1 hour glucose challenge testing, it can be performed any time of the day. Okay, the 1 hour glucose challenge test. It can be performed any time of the day, and then it doesn't require any fasting. The patient shouldn't fast. Okay, the patient shouldn't fast. Okay, the patient shouldn't fast. And then that one, we should be getting the patient glucose level below 140 milligram per deciliter. Please, let's take note. Okay, the 1 hour glucose challenge test, we should be getting the glucose level below 140 milligram per deciliter. That is 7.8 millimole per liter. Okay, 7.8 millimole per liter. That is the value you should get for. It's less than that too. Please let's take note. Okay, you should be getting less than this. Not that you should be getting less than 140 milligram per deciliter. Okay, you should be getting less than 140. That is when you do the 1 hour glucose challenge. Do it. You are not going to fast. So they were going to put 50 grams of glucose in your mouth. Okay, they will put 50 grams of glucose in your mouth. Right. They will put 50 grams of glucose in your mouth. Now, when they put the 50 grams of glucose in your mouth, they will wait for 1 hour, then check your glucose level. So after 1 hour, they must be getting your glucose level less than 140 milligram per deciliter. Okay, less than 140 milligram per deciliter. So that is for the 1 hour oral glucose challenge. Okay, challenge test. Now, if the person glucose was 140 or more, then you will require the patients to do the oral glucose tolerance test. Okay, then we require the patient to do the oral glucose tolerance test. You get it? That one is a 2 or 3 hours oral glucose tolerance test. Okay, so please, let's take note of that one too. Okay, all right. So that one, they will fast before the procedure, or they will fast before the test. Okay, they are going to fast before the test. Okay, they are going to fast before the test. So when they fast, they will inject the glucose once again, and then wait for at least 2 or 3 hours to draw the sample for the glucose testing. Now, if they wait for at least 2 to 3 hours, and then they draw the sample, and then they are getting 2 or more of the results being elevated, okay, that is above normal levels of the sugar level, then we conclude that you are having what? Gestational diabetes. Okay, let me go over again. Before a patient will be diagnosed with gestational diabetes, okay, they must undergo what we call the oral glucose tolerance test, and then the oral glucose challenge test. But then they all have hours attached to it. So let's take note. So we have the 1 hour oral glucose challenge test, and then 2 or 3 hour oral glucose tolerance test. So it is 2 tests. One is called 1 hour oral glucose challenge test, and the next one is called 2 or 3 hours oral glucose tolerance test. Okay, so one is challenge and one is tolerance. But they always begin with a challenge. Okay, they always begin with a challenge one. That one is for only 1 hour. So that one, you don't fast. The challenge test, you don't fast. They will ingest about 50 grams of glucose in your mouth. Okay. Then they will test your glucose level. They will draw your blood sample to test the glucose. If your glucose level is 140 or more, please note, after the 1 hour, if your glucose level was 140 milligram per deciliter or more, they must go on and then do the oral glucose tolerance test. Okay, but then if they check after the 1 hour for the challenge test, and then your glucose level is less than 140 milligram per deciliter, there will be no need for the tolerance test. There will be no need. okay, there will be no need. If it is less than 140 milligram or 7.8 millimole per liter, there will be no need. But the moment we check glucose level after the 1 hour in the challenge test, and then the glucose level is above normal, that is above 140, usually above 140, then they must proceed to do the what? Okay, that one is required. And then when they ingest the glucose, they will see two results. Okay, they are getting two results of the testing. I mean, within the 3 hours, they are getting the glucose level, two of them more than 140 or above normal. Then you can conclude that the patient have what? Gestational diabetes. So that is how we do this glucose tolerance and a challenge test. Okay. All right.
Give me this.
Yes.
Please, your network, it keeps breaking at a point in time. So if you could position yourself or check it.
Okay. All right.
Okay.
All right. All right. But is it okay now?
It's better now.
Okay. All right. Yes. Yeah. The second test, they still use the 50 grams of the glucose. Okay. The second test, they still use the 50 grams of the glucose. Okay. To help diagnose gestational diabetes. Okay. All right. All right. That is fine.
Hello, Basaki.
All right. So, yes, I'm listening.
Hello. The first one is
Yeah.
said that the second one,
Uh-huh.
how long will the patient fast? Or the 2 hour fast?
Yes. So, don't confuse. I think there's a let me clarify this. Okay. Let me clarify this. The first one, the patient does not fast. So that is when the patient is being, I mean, they ingest the 50 grams of let me say, of the glucose. Okay. But then that is a challenge test. Oh. But the oral glucose tolerance test, that one, they will fast prior to the checking of the glucose, right? So that one, they fast, and then when they fast, they will take the FBS, okay? They will take the fasting blood sugar and then note it down, okay? Hello, please, can you hear me? Or I'm still breaking.
Yes, we can hear you.
All right, is my network okay?
Yeah, it's okay.
Okay. So what I'm saying is that the glucose challenge test, the glucose challenge test, that one we ingest what 50 milligram of what 50 grams, okay. We ingest 50 grams of glucose, okay, in the procedure. They don't fast. So after we are done with the injection, 1 hour time, okay.
Oh,
Note,
Mr.
let me
You are breaking, cry.
kindly hold on. I think I have to change my this thing. See, the network is not helping me today.
But I think it's now better.
Let me, because there is breaking. Let me switch. Let me try and switch so that okay, we can have a smooth class. Oh, right.
I know it's better.
All right. Hello, can you hear me? Hello.
Yes, sir.
Yes, please. We can hear.
All right, all right. I need to change my listing. Okay. All right. So please, are we okay with the glucose tolerance test, or I should go over?
Please go over.
Okay. All right. So I was saying that we do two tests and to diagnose a patient with gestational diabetes. Usually, we do two tests. Okay. One is the oral glucose challenge test. Okay. Oral glucose challenge test. Now, in the oral glucose challenge test, it is for 1 hour. Okay. So you not fast prior to the procedure. The challenge test, you don't fast prior to the procedure. So the moment you come, they give you the 50 grams of glucose. Okay. They will ingest 50 grams of glucose. So after ingesting the 50 grams of glucose, they will wait for 1 hour. Then test your glucose level. Okay. If the glucose level, they check after 1 hour and it is 140 milligram per deciliter or 7.8 millimole per liter and above. Okay. And above. Right. And above, one thing you should know is that once they check and it is 140 milligram per deciliter and above, then they must consider the oral glucose tolerance test. But then in the challenge test, if they check and then your glucose level is less than, what do you call it? It's less than 140 milligram per deciliter, they will not worry themselves to check the tolerance test again. No. Okay.
Please, 140 or 1. I'm not hearing that part.
Yeah, I said 140 milligram per deciliter.
Okay.
Yes. So the moment they check and then your sugar level is 140 milligram per deciliter and above, then they must consider the tolerance test. Okay. So the tolerance test, that is what I was saying, that one, you fast prior to the procedure. Okay. The tolerance test, you fast prior to the procedure. Right. So you fast for at least 8 hours. Then they will check your fasting blood sugar. Okay. They will check your fasting blood sugar. So after checking your fasting blood sugar, they will note that one down. Okay. They will note that one down. Then they will ingest the glucose. Okay. Once again, they will ingest the glucose. Then after ingesting the glucose, they will test the sugar level after 2 hours to 3 hours. Okay. They will check it from after 2 hours going. Then they will note that 1, 2 down. So if after checking your sugar level after the 2 hours and then you are getting above normal, that is also above 140, even two of the results above the 140 milligram per deciliter, we can conclude that the patient is having what? Gestational diabetes. Okay. So that is the difference between the two of the tests. That is the difference between the two of the tests. Okay. All right. I'm sure we are okay.
Yes, sir.
Okay. All right. Yes, a hand is up. Yes, Mr. Yusuf.
Please, the injection of the glucose for both the 1 hour and then the other glucose tolerance test. Is this 50 gram or you have to increase it?
It's 50 grams. Please, 50 grams.
Okay.
All right. All right. Yes.
Please let's clarify the injection. I know it is drinking, but if you're not careful, someone will think that we will inject it into the veins.
No,
So,
I said ingestion. I didn't say injection. No. I said
okay.
ingest. Ingest. So yes, you put it inside the mouth. So that is why we said oral. So the
All
test
right.
is oral. Okay, not IV or IM or something. It is oral glucose test. Okay, so it is through the mouth. All right.
Yes.
That's fine. Yes.
In case you check the fasting blood sugar and it's above the 140, you still go ahead to do the OGTT.
This again, I can't hear you properly, please.
I'm asking that in case
Mhm.
you see you said the oral glucose tolerance test, you have to check
Mhm.
the patient's blood sugar, the fasting
Yes.
blood sugar.
Yes.
Yes. Now, saying that in case you check and it's above the normal, do you still go ahead to do the test, or is it
You
because
must,
it's above the normal?
no, you must note them. Okay, but then checking the fasting blood sugar and above normal already gives you the notion that the patient is already having a condition. Okay, but then you must still go ahead and check, because the procedure or the protocol is that after checking the fasting blood sugar, you go ahead and check the sugar level for at least 2 hours or 3 hours. Okay, and that's the protocol. But then if you check the fasting blood sugar and it's already high, it will give you a notion that this patient is already suffering from diabetes. Okay. Yes.
Okay, thank you.
Okay. Please, someone has his microphone. Raise your microphone and can the person with her, please? All right, please, can you move ahead? Or there's more question. Hello.
You
Are
can
you
move
okay?
ahead.
All right. So the another type or another diagnostic investigation, like diagnostic test, is the hemoglobin A1C. Okay, the hemoglobin A1C, HbA1c test. This one, it is done to test the amount of glucose in your hemoglobin. Okay, hemoglobin A1C is done to test the amount of glucose in your hemoglobin. And then the normal is 4 to 6. The moment the patient starts recording 7%, 8%, 9%, then it means that the patient is having what? Diabetes mellitus. Okay. So it should be between 4 to 6. Okay. Usually the hemoglobin A1C should be between 4 to 6. Someone may ask, what if you check and it's below 4? When it's below 4, it means that probably the amount of glucose in your blood is low. Okay, it's low. So you should get an amount of glucose in your blood as well. Okay, but then the normal should be between 4 to 6%. Above 6, that is 7, 8, 9, indicates that there is diabetes mellitus. Then we have the random plasma glucose test. That is the RBS we all usually do. Okay, the normal is 4.4 to 6.0. So this is when the patient eats, and then we test it after 2 hours. You can't test random blood sugar immediately after eating. No, we all know that after eating, the patient is going to have what? High sugar level. That is what I said earlier on. The moment you eat, there's increase in your glucose level. So you must give the pancreas and the insulin some time, at least 2 hours, so that the insulin will do its work by pushing the glucose from the blood into the cells. Then after the 2 hours, we can check what? We can check for the presence of the glucose in the blood. So if after 2 hours we check and we are still getting high sugar level, that is above 6.0, then we can conclude that the patient is having what? Diabetes. Okay. All right. Then we have the
with the HbA1, do you also have to fast?
hemoglobin A1C. No. We don't fast. No.
Okay.
Yeah, no, we don't fast. You don't fast. Okay. Yes, you don't fast. That one is simple. You just take your blood sample to the lab and test for the presence of glucose in your hemoglobin. Okay. That is how they do it. All right. Then the last one is the urine glucose test. So you do a urine collection. You urinate inside a container. We send the container to the lab, and then you know how we do this. Okay, just a dipstick into the urine, and then we are going to find the presence of glucose. Okay. So that is how it is done, and this can help diagnose what diabetes mellitus. Okay. All right. Then we have treatment for diabetes mellitus. Treatment for diabetes mellitus.
Yeah,
Okay.
hello, sir.
Yes. Hello.
I wanted to find out what are the differences because most of the lab tests, the hemoglobin and then the random, they are all blood samples that we take. So, what are the differences? Because you still take a blood test. So, are they going straight into maybe like the red blood cells or to get a hemoglobin before we do that?
Exactly. Of course. Okay, the RBS and then the FBS, we usually do it on our ward. Okay, that one, you don't really have to go into the lab or send the sample to the lab. Okay, and that one, we use another prick. Okay, but this one, they will take a blood sample, like putting it into some of the containers that we have, the move container that we have around. Okay, like unlike the prick we usually use the glucometer for, the RBS and the FBS. No, this one, they will take the blood sample to the lab and then make sure they are able to have access to red blood cells and hemoglobins and test for the presence of glucose in the hemoglobin. Okay. That is how it is being done. Okay.
Hello, sir.
Yes.
Sir, please, with the fasting blood sugar, I want to know what signs do we
What
call
time?
it fasting? Sometimes, yes, because sometimes the patient can come at, let's say, 11, and the patient will tell you that having eaten. So do you still refer this as fasting blood
Fasting.
sugar or
Yes. Yeah, it is still referred to as
it's still,
fasting blood sugar.
oh, okay.
Yeah, since you've not eaten, no food has gotten into your mouth for there to be an increase in your glucose level. Okay, usually. So before you, since you are fasting, you've not eaten, it is still termed as fasting blood sugar. But then let me say this, okay? The correct
Please,
time of,
please, the question again. The question again.
okay, she was asking that, for example, a patient comes to the unit at 10 a.m. and then you check the sugar level. Is that still fasting blood sugar? That was the question. And I'm saying because the patient, yes,
Okay. So our doctors said
mhm,
true fasting blood sugar should be taken around 6 to 7 a.m.
yes,
If you come to do fasting blood sugar later in the day,
mhm,
they wouldn't see it as a true reflection of fasting blood sugar because
of course.
just as the mechanism you explained, when the
Mhm.
body starts to
Produce
fast or when the body stays away from food for
a
some number
long
of
time.
hours, glucagon will start stimulating, will be produced, and then glycogens will start to be converted into glucose in the liver. So your body has
Exactly.
started producing glucose into the system. So they
Exactly.
wouldn't be able to really assess whether it's a fasting blood sugar. So it should be done
Exactly.
very early in the morning, else either they won't do it or they regard it as random or you have to repeat the test. That's what
Later.
it says.
It's true. Okay, that was what I was going to say, and then I think you came in. Okay, so in as much as it is believed that the moment you've not eaten, and you test for your sugar level, once you've not eaten, we say fasting blood sugar, right? That is what we know of. Okay, once you've not eaten, and then you check your sugar level, we say it's fasting blood sugar because you are fasting, you have not eaten. Okay, but then as Madam, our sister just said, once you are fasting, you are not eating for like at least 8 hours, the body will start to compensate. Now the body will start breaking down glycogen into glucose, but the liver, there will be the fat will start breaking down itself to ketones, and so you begin to have some glucose in your blood. So if you check your sugar level late in the day, 10 a.m., 9 a.m. to like any other time as above, let's say 8 a.m. Okay, you are likely to get a false result. Let me put it that way. Okay, you will term it as fasting blood sugar, but then that will not give a true reflection as Madam said. Okay, all right, so that is fine. I'm sure that is okay for all of us. All right. So the treatment for diabetes, okay. First of all, we have their diet, okay. When you have diabetes mellitus, you have to take note of your diet very, very well. You don't have to consume high carbohydrate diet, okay, because these carbohydrates, the moment they digest, and their end product is sugar, okay, their end product is sugar. Already there's an increase in glucose level already, okay. So for diabetes patients, okay, one thing that you should encourage them to do is that they shouldn't consume a high uh, they shouldn't consume a high carbohydrate diet. Okay. They shouldn't usually consume a high carbohydrate diet. because when they consume that, it's not good. And then they should take in less fat diet. As I explain later on, when you are fat, there's increase in fatty acid and fat deposit. This alone can hinder insulin. Okay, so you take in low fat diet, low carbohydrate diet. Okay, low carbohydrate diet. But then for the protein, usually they can take in a moderate protein diet. Okay, usually they can take in a moderate protein diet. So that is something that we should know when it comes to their dietary, or when we say healthy diet in diabetes. Okay, so that is one thing that we should take note of. All right, then they must engage in regular exercises. Of course, I said that exercise does what? Exercise increase the body sensitivity to insulin uptake. Okay, so if you don't exercise, you render the body dormant to be sensitive to insulin. So they must engage in what? Regular exercises. Okay, very good. Then 3, weight management. Of course, this one linked with what? Obesity. If you are obese, what occurs? There is increase in fat deposit, and that can interfere with insulin effectiveness. Then 4, stress management. Okay, you must manage your stress very, very, very well. Right? You must manage your stress very, very, very well. Okay, let's not forget, because when you are under stress, yesterday we learned about catecholamines and aphicromocytoma. Okay, when you are stressed, then catecholamines are being released, and then catecholamines are being released to help you respond to the stress. So if you are going through a lot of stress, and then there's more production of this catecholamines, let's not forget yesterday we learned this, that catecholamines has a way of what? Suppressing insulin effectiveness, or suppressing insulin release from liver and then the rest, okay, and the pancreas. So when there is excess release of catecholamines, it interferes or it blocks the release of insulin from these liver and then these pancreas, and therefore increase what? Your sugar level. So anytime a patient is having diabetes, they must, in fact, manage their stress very well. You must educate them to identify their stresses. I mean, things that predispose them to having the stress. Okay, you must educate them to identify their stresses, and then they manage them as such by counseling them, and then taking them through effective education for them to manage their stress. Okay, very good. Now, medications that we can give in diabetes, we have the oral hypoglycemics and then the insulin therapy. So the insulin, we'll talk about it later, okay, as we are going on. We will do that one. I mean, the NPH, the regular, and then those stuff. We'll talk about it just now. Okay. So the medications, we have the oral hypoglycemic. So we have the metformin and then the sulfonylureas. Sulfonylureas, the other name for sulfonylureas is what? Who can remind us? It's a question, just a question. Sulfonylureas. You have another name you call it. Oh, we've heard of glyburide before, right? Glyburide. Right. So let me talk about the sulfonylureas, okay? Our other name is glyburide, okay? Glyburide. And then this drug in particular shouldn't be given to older patients with diabetes, okay? This drug shouldn't be given to older patients with diabetes. The reason is that this drug really causes hypoglycemia, serious one, okay? So when you give it in an older patient, it can cause their sugar level to drop drastically, because as I said earlier on, aging have a severe effect on what? Aging have a severe effect on what? On your glucose management, because when you are aging, how the body will respond to insulin is even a problem. Okay, so glyburide is not usually given to older adults. Please, let's take note, okay? It really increases. And then one thing about the glyburide is that it prolongs hypoglycemia in older patients. Those who are old. It prolongs the glyburide, okay? And one thing you should also know is that, when you are aging, as I said, because of degeneration, even how the kidney function to excrete drugs after it has been taken is also a problem, okay? And then this drug in particular, their elimination sometimes take time before they can be eliminated. So don't give these drugs to what do you call it? Older patient or geriatrics, okay, those who are very, very old, okay, but then they can take the metformin rather, okay, they can take the metformin rather. Now, how does metformin work to reduce your sugar level? Okay, metformin works by increasing the body sensitivity, okay, it increases the body sensitivity to insulin. That is how metformin works, okay. When you give someone metformin, the metformin will work by stimulating receptors, the insulin receptors by the cells, okay. So it increases the sensitivity of the insulin receptor so that the moment the insulin is being released, it can take it up, okay. And then also it reduces the amount of glucose being produced by the liver, okay. So when you start taking metformin, the amount of glucose being produced by the liver will be diminished. Therefore, there will be no hyperglycemia. Okay, so that is how metformin works. Okay, that is how metformin works. Metformin works by increasing the body sensitivity to insulin by what? By stimulating their receptors, or it works by diminishing the amount of glucose being produced by the liver. Okay, very good. Then we have the insulin therapy. So that the insulin, as I said, we'll talk about that. So we have the NPH, the regular insulin, the long acting, the rapid acting. They are all given to decrease your sugar level. Okay. The artificial insulin. So in a situation whereby the body cannot produce the insulin, then you must give what? An artificial one to do that work, okay, for the body, so that they will push the glucose from the blood into the cells. Okay. All right. Very good. So we have surgical options. Very good. So we have the pancreas transplantation and then the islet cell transplantation. The islet cells, they are all in the pancreas. Okay. So we have pancreas what? Transplant. So if the patient had pancreatitis and then the pancreas has been damaged for a longer period of time, that become chronic and the pancreas has been damaged. Therefore, we must and then we have to recommend a transplant. Then we have to look out for that so that the diseased pancreas will be taken away, and then there will be a transplant of of the pancreas. Now, let me put this across on your ankles. On your ankles, right? This one, it goes for every other transplantation, whether it is kidney transplant, liver transplant, whatever transplant they will do. Please note this on the ankles. They usually, I mean, this one is somehow common on the ankles. Okay. When you are, what do you call it, transplanting an organ, the moment you finish transplanting the organ, let's say, for example, okay, God forbid, but let's say I have an issue with my pancreas and then they have to transplant a new one for me. Okay. Because the new one they are bringing is not my body. I mean, it's not something in my body. The body begins to reject it because how my body was made up, how my blood vessels respond to my body. Now you are taking my organ out, you are bringing the new organ. So when the new organ comes, the body sees it as a foreign body, so it begins to reject it. So please, let's take note. Anytime transplant occurs, that is what occurs. Okay, the body sees the organ being transplanted as a foreign body or a foreign object coming to harm the body. So the body must do what? Counter it by rejecting the body. So usually, when you undergo transplantation, the person must take an immunosuppressant. The patient or the person must take an immunosuppressant to suppress the immune system, to prevent it from rejecting the organ, because usually it's the immune system that will trigger the rejection. Okay, so we give the immunosuppressant to suppress the immune system so that there will be no rejection of the organ. Okay, so please, let's take note. Okay, so if a patient undergoes transplantation of the pancreas, let's say a patient with diabetes with high sugar level for long time, and now there's a need for us to transplant the pancreas. Okay, and then you've done it, and then still the patient is suffering from high sugar level, then it means that there's a rejection. Okay, there's a rejection going on because instead of us to have, I mean, a well-controlled sugar level, we are still having a high sugar level, even though we've transplanted a pancreas. See, what comes to mind is simply tell you that there's a rejection somewhere. Okay, so we don't want that one to occur, the rejection to occur. The moment the patient undergoes transplant, we give an immunosuppressant to suppress the immune system so that the organ can function properly. Now, because of this, what comes into mind once again on our ankles? Neutropenic precautions, checking patients effectively for what? Infections and what? Yes, for infections. So you prevent overcrowded areas. You keep neutropenic precautions. Okay, there shouldn't be any soil or sand in the patient's bed or patient's room. There shouldn't be any flour in the patient's room. Okay, very good. Patients shouldn't be engaged in like gardening. I mean, when I say gardening, you shouldn't go to garden, plant flowers, and no, all these things should be stopped. Patients shouldn't be exposed to what? To overcrowded areas. Okay, and then you must limit visitors. All this goes into what do you call it? Neutropenic precautions to prevent infection. Okay, then what again? You keep the patient in what you call what? Reverse isolation. Reverse isolation. Okay, reverse isolation. Anytime the patient is having a low immune system level, you keep what? Reverse isolation. In reverse isolation, what do? You put the patient in one room, okay, so that nobody will be coming in and out often to infect the patient. So here in reverse isolation, we are keeping the patient from what? Infection outside. That is what we do in reverse isolation. So please, let's take note. You can get a question on your ankles. Patient with diabetes underwent transplant, a patient with kidney failure underwent transplant, and then now there's immunosuppression by giving the immunosuppressant. And then you must keep neutropenic precautions, you must keep reverse isolation, you must know all these things. It must be at the back of your mind anytime you are dealing with some of these things. Okay. All right. So that goes into the pancreas transplantation and the islet cell transplantation. Okay. All right. That is it. Any questions so far? We're talking about it. Please, can you mute up? If you're not speaking, kindly mute up, please. Hello. Oh,
Hello.
yes.
Hello.
Yes. Please can talk. Yes.
Yeah, please, what I just want to say is that with
Mm-hmm.
the metformin that you spoke about,
Mm-hmm.
the function or whatever you said about metformin, that when we
Mm-hmm.
take metformin, it increases the body's sensitivity to the insulin. I just want to say that someone went recently to
We
write
can't
and have
hear.
a,
No,
you can't hear
madam.
me.
Please, I heard what you were about to say, but please, I will not allow you to say it, okay? Okay. I will not allow you to say it. All right. Sorry for that. Okay. Sorry for that, but I will not allow you to say that. Okay. All right.
Hello.
Yes.
Okay, as you've spoken about metformin, can I contribute something about metformin so that we have an understanding? Is it okay to talk about it?
Yeah, but please, wait. Let me say this. Okay.
Okay, okay.
So this, Madam Annette, sorry, I said I will not allow you to speak about this because, you know, the moment you said
I
a person went,
understand.
yes, all right. So, sorry about that. Okay. All right. Yes, Madam Zara, please talk.
Okay, I wanted to add these things has been appearing most of the time.
No.
When I saw question.
Madam Zara, when you solve questions where kill banks away. Madam Zara, hello. Please, anything, you know, we don't encourage, we don't have to encourage past questions, okay? Actually, we don't encourage that because, what do you call it? We are speaking to, or we are doing a global thing, okay? So we don't encourage, and it's against NCSBN rules, okay? Madam Zara, is it kill banks that you're talking about? If that one you can speak, please. But she's not here.
Hello, somebody has muted me.
Yeah,
I'm saying that you are not allowed to talk about Q banks as well, or what?
Oh, we can talk about kill banks, yes, we can talk about kill
Yeah,
banks.
because you didn't let me land.
Sorry about that. Sorry.
Okay, so I'm saying most of the time, anytime I solve questions, I see question on metformin. that says that a patient who is going for a procedure that has to do with dye has to
Okay.
you have to pause the metformin for like 48 hours before the procedure, and when they come back from it, you have to give them the medication within 24 to 48 hours. So that's what I was going to say, just to chip in. Thank you.
Okay. Yes. And then when you give it, when you are giving the dye, what occurs?
Lactic acidosis.
Lactic acidosis. Okay. This is common. It's common. It's common in all the kill banks. All right. That is fine. So can we talk about the complications? Please, any question or contributions? Again, or we
Please,
can
can
talk
you
about
kindly explain what she said? I have not come across it yet.
Oh, for example, if especially they link this one in kill banks, they link it with cardiac catheterization, okay? Because when you are going for cardiac catheterization, they give you a contrast medium, okay, like a dye. The duty of the dye is to ensure that the procedure can be done very well. I mean, it helps us to visualize the arteries and everything is very, very well. Okay, so when you push it through, everything becomes a bit clearer. Okay, so it's a contrast medium. And then the reason is, one thing is that when you are going for a such procedure, which you'll be given a dye or a contrast medium, you don't take metformin within 48 hours before the procedure, and then 48 hours, let's take it like that, 48, okay? 48 hours before the procedure, and then 48 hours after the procedure. Because when you take metformin and then you receive the dye, it's going to cause lactic acidosis, okay? That is what is going to result. So that is why you don't take metformin, and then you don't also take what do you call it? I mean, you don't take metformin 24 to 48 hours before and after the procedure. Okay. All right. Very good. So we can talk about the complications now, right? So one, we have diabetic retinopathy. Okay. Diabetic retinopathy. This one is a common complication of diabetes. Now, when there is excess production of glucose, diabetes, it is very common, but then it is very serious situation or serious condition. Okay, it can lead to blindness, right? It can lead to blindness. So, under diabetic retinopathy, when there's excess production of the glucose, okay, or when there's too much glucose, what occurs? The too much glucose tends to destroy blood vessels around the retina. Okay. So when the blood vessels around the retina is being destroyed, then blood supply to it is not what? It's not achieved. And this alone can affect how the eye used to what? See, or how the eye functions properly. So let's take note, okay? Who is right on my screen? Okay, let's take note. Okay, so excess production or excessive glucose level affects the blood vessels around the retina, and then this will lead to diabetic retinopathy. So a patient comes to your ward with diabetes. 5 days, 6 days after, patient starts complaining of what? Blurred vision, not able to see well. Start thinking of what? Retinopathy. Now, if blindness sets in the long run, if there is blindness in the long run, you must know what goes in when it comes to managing someone who is blind. Okay, one, when you're managing someone who is blind, you must always introduce yourself when you enter their room. I'm sure you've come across these questions as well when solving Q banks. Okay, you must always what? Introduce yourself when you enter their room. Okay, so I am nurse so and so. Okay, always use the clock. How did they even put it? Okay, the clock sign to teach patients where their items are. So you all know how when you see a clock, okay, there is 12 p.m. here, or let me say 12 o'clock here. There is 3 o'clock here, 9 o'clock and 6 o'clock, right? So use that idea to teach the patient how to locate their items. Okay, so teach the patient now. When you sit on your bed and you look straight, that one is what? 12 o'clock. Here you are going to locate what? Your brush, you are going to locate your comb. So always use that way to locate your comb. Now, when you look on the right, that is 3 p.m. or 3 o'clock. Here, you locate your trousers, you locate your t-shirts and everything. You see how it is being done. So you use the clock, the clock or the timing to teach the patient how to locate items. Okay. Always put things in patient's reach. Okay. always put things in patient's range. Don't separate things like that. Okay. And then you make sure that what there's a call bell or a call alarm in the patient's room that the patient can use to call you in terms of any emergency. Okay. All right. So that is fine for retinopathy. Then you can have diabetic or diabetes nephropathy. Okay. Diabetes nephropathy. This one too, I think it has a correlation with the cardiovascular system. I said that anytime there's something wrong with your heart, think about kidney also, because when there is diminished blood supply to the kidney begins to fail. And then in diabetic nephropathy, okay, once again, there's excess production of glucose. Okay, when there's excess production of the glucose, and when there's excess production of the glucose starts to block blood vessels, as I said earlier on. Now, these blood vessels will begin to have what? Begins to narrow. When they are narrowed, the heart will be pumping all right, but the blood flow to the kidneys will be affected. And this can also cause what? Can cause nephropathy. Okay. So we start looking out for kidney symptoms. Then we have diabetes neuropathy. Good. Where nerves are being affected. Okay. Your nerves becomes affected. Okay. So diabetes neuropathy, your nerves becomes affected. That is excess glucose production has a way of damaging your nerves. Okay, so the nerve cells become damaged by the excess production of the glucose, and this is what we call diabetic neuropathy. Now, because of this, patients can start getting what we call foot ulcers. Okay, foot ulcers, because their nerves are being destroyed. There's no blood flow. I mean, blood flow is affected, nerves are being affected. Okay, so there can be foot ulcers and all those. You tag the patient, patient start having tinglings and tingling and all this stuff. Now, I'm sure some of us have come across this drug. We give in diabetic neuropathy, okay, to prevent it. What drug is that? Is that what? Hello?
Is it pregabalin?
Is it Neuromin?
No, not
Pregabalin.
Neuromin.
Is it pregabalin? Lyrica.
Amitriptyline is also used.
Is that what?
Amitriptyline is also used.
Amitriptyline is also used. Okay, all right, that's fine. Okay, and then neuromin can also help a lot with the neuropathy. When your nerves are not functioning, you can give neuromin as well. But what relation does the neuropathy have with vitamin B6, pyridoxine? What does it do? Or you've not heard about that?
Yeah, it helps with nerve repair.
Yeah. So we can give what do you call it? Vitamin B6. Okay. Oh, that one is when you are taking isoniazid. Okay. So we combine. So that is what I was trying to chip in. Okay. When anytime a patient have TB, if you are having TB, okay, if you are having tuberculosis, and you are prescribed isoniazid can do what? Can cause neuropathy. Okay. Oh, you said what? Niacid. Please take it like that. Okay. So when you give this drug, when you give the isoniazid or isoniazid, it can cause neuropathy. So usually we combine it with vitamin B6 or pyridoxine to prevent the neuropathy, the damage of the nerve. So please take note. I just wanted to chip this in. Okay. When a patient is being prescribed isoniazid for TB, it can cause neuropathy. It can cause neuropathy. Please, who is speaking back? Okay, it can cause neuropathy. Okay, so to prevent the neuropathy, we give vitamin B6 or pyridoxine in addition to prevent this. So let's take note. Okay, all right. Then 4, we can have cardiovascular diseases. Of course, I think I've said it here time and again. Okay, there can be cardiovascular disease like hypertension because of the accumulation of glucose in the blood vessels. Okay, so this can even lead to stroke, like hemorrhagic stroke, because of the hypertension. Okay, then 6, we have foot ulcers. Okay, this one too is a bit common I think we've been seeing it in our case studies and all those stuff. Okay. So let's talk about foot ulcers a bit. So how do you care for diabetic foot ulcers? Okay. How do you care about it? So let's talk about some of the care. So one, you wash the feet daily with warm water, okay, and mild soap. Okay. You must always wash the feet with warm water and then mild soap. Okay. And then before you bath them or you wash their feet, always test the temperature of the water before you use it. Okay. Always test, because the nerves are being destroyed. They don't hear, they don't feel anything. Sorry. They don't feel anything. Okay. So the nerves are being destroyed. Okay. So let's take note. Okay. So you wash their feet daily with warm water and mild soap. Before that, you must test the temperature of water before you do that. Then you have to gently pat dry. Okay. You have to gently pat the feet dry. Particularly, you must pay attention to the patient's toes. Okay. You must pay attention to the patient's toes. Okay. Then you can use this lotion, or let me say cream or something. Okay. The lanolin, Lanolin. So you can use lanolin to prevent dryness and cracked skin. Okay. And then you don't apply this between toes. The naloxone, you don't have to apply it between toes. Okay. So you use naloxone to do or to prevent dryness and cracked skin. Okay. They shouldn't walk barefooted. Okay. They shouldn't walk barefooted. They shouldn't walk barefooted. Please take note, because when they step on, let's say, anything sharp, they will not even feel it because of the what do you call it, the neuropathy. So they shouldn't walk barefooted. Okay. And then to improve circulation to the area, to their foot, they shouldn't cross their legs when they sit down. They shouldn't cross their legs when they sit down. Okay. They shouldn't cross their legs when they sit down. To improve circulation to the area, they shouldn't cross their legs when they sit down. Okay. Very good. So these are some of the things. And then also when it comes to cutting their their nail, okay, you cut toenails straight across, and then you use a nail file, okay, along the curves of the toes. You must be careful not to cut the patient, okay. So you just have to cut the toenails straight across, okay, to help prevent any injury and other things. So please, these are some of the things that you must know when it comes to foot ulcers, okay, foot ulcers. And then lastly, if there's severe neuropathy, okay, there's severe neuropathy, nothing is working with regards to giving neuromin, giving other medications and all this stuff, it's not working out. They can consider what amputations, and then the foot will be amputated. So that is one thing that we should also know with regards to diabetes. Okay. All right. So that is that for diabetes mellitus. We'll talk about EKA as well, the major complications of diabetes. Please, any question with respect to whatever we've learned so far? Please.
Yes, sir.
Yeah.
Please, sir. With the management of the diabetic foot ulcers, I think my network misbehaved, so I was taken off at the beginning of it. I didn't hear it well. If you can repeat the beginning part of it, the management of the diabetic foot ulcers.
Oh, okay. So I said that. So let me just go by it quickly. Okay. Okay. You wash the feet daily with warm water and mild soap. Wash the feet daily with warm water and mild soap. Test the temperature of water before you use it. Okay. Test the temperature of water before you use it. Gently pat dry, especially the toes. Okay. You must gently pat dry the feet. Okay. Use lanolin to prevent dryness and cracked skin. Okay. Use lanolin to prevent dryness and cracked skin. Do not.
Of the lanolin. The lanolin.
Lanolin. Lanolin. Okay. Do not cross the legs when you sit down to improve circulation to the area. Already there is neuropathy. Okay. All right.
I've gotten it.
Yes. Do not walk barefooted. Okay. Do not walk barefooted. And you cut their toes straight across. Okay. you cut their toes straight across. All right, so that is that for the foot ulcers, the care, the diabetic foot care. Okay. All right, please. Any question? How should we treat DKA? Any question, please? Any question? Oh, we are okay.
Yes.
Is it that we understand everything?
Yeah, please, I have a question.
Okay.
With the management, the medical management, especially pharmacological management of the DM, where you talk about metformin. Is it only metformin that can be used? The others, I know of glibenclamide, glimepiride.
Yeah.
Those one,
you
one
can give
belong
them
to the class, but I don't know
which
whether
class?
is glibenclamide that belong to the biguanide or is the glimepiride I've forgotten of. So I wanted to find out the other drugs that can also be used to manage.
Oh yeah, you can
and
give.
Maybe
You can give. Yeah, glimepiride. You can give it. Okay. You can give it. Okay. Yeah.
is it
You said
I'm giving a low or in combination with metformin?
They can be given alone. All those drugs fall under sulfonylureas. So glimepiride, gluburide, all those drugs fall under sulfonylureas. Okay.
Okay.
Gluburide, glimepiride are class of sulfonylureas. Okay.
Okay.
Yes.
The metformin too belong to, is it the same sulfonylureas or that one is
You said
biguanide? Metformin itself, does it also belong to
biguanide. The biguanide.
Biguanide. Yeah. Okay.
Yes. But one thing is that it's good that we know, but then the NCLEX usually does not focus much on the class of the drugs. Usually, I repeat once again, on pharmacology on the NCLEX, usually you focus on what? You focus on the side effects when the drug is being taken, okay, then the contraindications. It is even in few times that they bring mechanism of action, okay, in few times that they bring mechanism of action, and then metformin, I give the mechanism of action for metformin, right? It works by increasing the body sensitivity to insulin, and then it also prevents the production of glucose from liver, okay. So that is it, okay, yeah. All right. So diabetes ketoacidosis.
Hello, sir. Please, I have a question.
Okay, you can ask.
Oh, okay. Regarding the foot care that you give, is it foot care for diabetic ulcers?
Yeah, diabetic foot ulcers.
Or is just a general foot care for diabetics?
No. When you have, not everybody have diabetic foot care. Let me what did I say?
Not everybody has ulcers.
Have the ulcers. Not everybody have the ulcers. Okay. Of course, we know people around. Who have diabetes, they can walk, they can walk barefooted. So those who have the ulcers to the point that there's severe neuropathy, damage of the nerves, this is what goes for them. Okay.
Okay.
Yeah.
So it's to do with the care of the foot and not the ulcer itself.
Yes, care of the foot.
Yes, because for the presentation that. All right.
Yeah, yes.
All right, thanks.
You're welcome. Someone also was asking another question, please.
Yeah. I think I don't know if we can elaborate more on insulin. Like, we have the short acting, the long acting, and other things, because I met a question that they were asking the type of insulins that you can draw together, whether you can draw the two of them into one syringe or you have to use different syringes to withdraw such insulins. And I think that was the first time I had encountered such kind of question.
So we are going there. I said that we treat it. Okay, so it's in our next slide. Very soon we'll talk about it.
Okay, thank you.
You're welcome. Is any question before you proceed? Any question? Oh, we are fine. Hello. You can move in.
Yes, please.
All right. Let's try and finish. Diabetes is broad, though. It's very, very broad. But let's try and see if we can finish. Okay. All right. So DKA, diabetes ketoacidosis. This one is a complication of type 1 diabetes. A life-threatening one. Okay. A life-threatening complication of type 1 diabetes. Let's take note. Okay. A life-threatening complication of type 1 diabetes. Okay. Now, once again, let's go back to how I began the foundation. So I said it, when you understand our principle, diabetes should be easy for you. Okay, when you understand the foundation I gave yesterday, it should be easy for you. So once again, in type 1 diabetes, what is going on? They are insulin dependent. For them, they don't produce insulin at all. Like there's no production of insulin, the type 1. So they depend on insulin solely. Okay, all their life, they must depend on insulin. Now, because there is no production of the insulin at all, what occurs? There will be no shifting of glucose from the blood to the cells for energy because there's no production of insulin. Okay, so the cells is being starving. And then if the cell starves for a longer period of time, the body begins to break down stored fat, stored glycogen. Okay, so the breaking down of the stored fat, we get ketones. That is where we get diabetic ketosis. So I'm breaking the definition down so that we understand. When the cells are being starved for a longer period of time, they are not getting the glucose. The body begins to break down stored fat. When they break down the stored fat, we get what we call ketones. Okay, so we get diabetic ketosis. Now the acidosis comes from the ketone because ketones are acidic. Okay, ketones are acidic. So the breakdown of fats into ketones makes the body a bit acidic because ketones are acidic in nature. Or let me say, one characteristic of the ketosis or ketones is that they contain a lot of what? Acid. Okay. That is when we come about with what? Diabetes ketoacidosis. So on my screen, I think I even see it on my screen. Okay. A life-threatening complication of type 1 diabetes. So there's lack of insulin. The body is not producing insulin at all. So there's no energy. There's no glucose in the cells. Therefore, there must be breakdown of fat. And when there's a breakdown of fat, we have ketones and acidosis. This is what we call about, or we say there is what? Diabetes ketoacidosis. Let's look at the signs and symptoms. So the signs and symptoms, it has been grouped what? Under the definition, or sorry, under the acronym DKA, just as the name suggests. Okay, DKA. So the D stands for dehydration. Okay, the D stands for dehydration. The K, one stands for ketones. The other stands for hyperkalemia. So I just did kalemia. Okay, the kalemia comes as a result of the acidosis. Okay, this one, let me talk about it. So anytime there is increase in acid level, there's also increase in your hydrogen ions. Hydrogen ions will cause your potassium to rise. Okay, so we have ketones, we have hyperkalemia, then we have Kussmaul respiration. The body, the patient begins to breathe faster. Okay, to take away or to get rid of the excess glucose. Okay, so they have what we call the Kussmaul respiration. So we have D standing for dehydration. Please can we mute up? If you don't talk, please kindly mute up. D for dehydration, K for ketones, hyperkalemia, and Kussmaul respiration. Okay, then A, we have anorexia. So they begin to have, some kind of anorexia. They can even vomit sometimes. Okay. Then we have the acidosis. Acidosis comes from the ketones, as I said. Then we have acetone breath. Okay. The fruity odor or acetone breath. Okay. Because of the glucose, when they breathe, you can hear some, you can sense some smell. Okay. Like a fruity odor. That's what we call the acetone what? The acetone breath. Okay. So these are the key signs and symptoms of DKA. Let's take note. The key signs and symptoms of what? Diabetes ketoacidosis. Okay. All right. Now, how do you diagnose DKA? Okay. So the moment you start suspecting that the patient's sugar level is
Mr.
going,
Kim, this.
yes.
Please kindly previous slide a minute, please.
Okay. So we have DKA, okay. The acronym for diabetes ketoacidosis. At least this one should guide us. D stands for dehydration, K, ketones, hyperkalemia, small respiration. A is anorexia, acidosis, acetone breath. Okay. All right. Then how do you diagnose DKA? So the moment you suspect, okay, that a patient is having a sugar level around 250 milligram per deciliter, someone should convert, or let's convert 250 milligram per deciliter in to 2 millimole per liter, please. Let's convert. What are we getting?
Please, the question again.
I said let's convert
13.8.
Let's convert it to
Okay.
250 milligram to
13.8.
10.8. I know of 13, but not my favorite presentation. Okay, 11.
Yeah. So that one is yes, but then when you start getting a sugar level around 250 milligram per deciliter, okay, you start suspecting what? You start suspecting DKA, okay. But then in some what do you call it? In some literatures, they gave 11 millimole per liter instead of the 13, okay. So that one will be around, let's say, 198 milligram per deciliter, okay. In some literatures, they give out the 11, okay. In fact, most of the literatures I have read from Kilbans, they actually give the 11, okay. So we can just say 198 to 250 milligram per deciliter, or 11 to 13 millimole per liter. Let's keep it within that range, okay. The moment we start suspecting a sugar level within that range, we should start thinking of DKA in type 1 diabetes, okay. Very good. Then 2, urinalysis. So we take a patient's urine sample, you send to the lab, and then when you send to the lab, we were able to test for the presence of ketones. That can be used to diagnose DKA. Then 3, serum for elevated ketones. Of course, you draw the blood sample, okay, and we test for the presence of ketones in your blood, and that one too is going to be very, very high. Then electrolytes is going to be what? Hyperkalemia, okay, hyperkalemia. But usually the focus is really on the glucose level, okay. Please, let's take note. 11 millimole per liter to 13, okay. So that is something that we should take note, okay. Millimole per liter, or 250 milligram, 198 250 milligram per deciliter. Okay, so that is how we can use to diagnose DKA. Okay, now let's talk about nursing interventions. How do you manage DKA? Now, please, let's take note, okay. On this slide, the same thing say, you see, I didn't mention anything like polyuria, polydipsia, and then the polyphagia and all those stuff, because we know them already. Those are the fundamental symptoms of diabetes. In both situations, DKA or whatever, it is still there. Okay, so please, let's take note. Okay, very good. So because the patient is going to urinate a lot in DKA, there's polyuria, you can give them IV fluids, okay, especially isotonic saline, that is the 0.9 normal saline. We don't give them the 3%. 3% is hypertonic, okay, and then 0.45 is hypo. So usually we give them the ISO, the 0.9. This one will increase the fluid volume in the intravascular space, okay.
Okay.
So we give them the IV fluids, and then we administer. Yeah, hello. All right. Please, can we mute up, please? Then we administer IV regular insulin. Okay. So this one too, we give it as a continuous. Oh, please, can we mute up? Okay, so we administer regular insulin. So the regular insulin will ensure that the patient glucose level drops to normal range. Okay, drops to normal. But then one thing we should know is that the regular insulin, it's like, because we are giving IV, it can cause severe hypokalemia. So every hour we must check for the patient's sugar level. Okay, in as much as you want to reduce the sugar level, we should reduce the normal range. If it comes down or it comes too low, it can also cause hypoglycemia. So the moment we start the regular insulin, we should start monitoring the patient glucose level every hour. Okay, every 1 hour. We should start monitoring the patient's sugar level every 1 hour. Okay. Then you monitor the patient's arterial blood gas level. Of course, there's going to be what? Metabolic acidosis. Let's take note. There's already acidosis because of the ketones. So you have to monitor the patient's arterial blood gas level. Anybody with confusion with metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis, don't worry. By next week, it should be cleared because our webinar will clear all those confusions. Okay, very good. Then if you start suspecting hypoglycemia, okay, after setting up the regular insulin and you start suspecting the hypoglycemia, quickly you change it and you give 5% in water, 5% dextrose in water. That is D5W. So I've seen this question in case in K-Banks, okay. A patient was receiving regular insulin for DKA. Patient starts recording low sugar level or patient starts getting into hypoglycemia. Which of the following should you anticipate to give? So you should look out for what? D5W or 5% dextrose in water. Okay, 5% dextrose in water. That is what we give when there's hypoglycemia. Okay, then you monitor for rebound hypokalemia after insulin administration because insulin shifts potassium from the blood into the cells. So the moment you start giving insulin, okay. So this question, it can be a likely question on your NCLEX, right? A patient starts taking insulin for DKA, then the patient starts running into hypokalemia because insulin does what? It pushes potassium from the blood into the cells. So you are going to go into hypokalemia. Then when you get this question, what do you do? The moment you suspect what? Hypokalemia, how do you do? First of all, you have to regulate the insulin or probably have to stop it because if there's severe hypokalemia, there can be cardiac arrhythmias. Okay. So you reduce or you stop the insulin level, the insulin distance. I mean, you stop the IV fluid. Okay, the insulin administration, you stop it. Then you initiate cardiac monitoring. You put the patient on a cardiac monitor. For hypokalemia, you put the patient on a cardiac monitor because there can be chances of cardiac arrhythmias. Then you monitor the patient's ECG very well. Okay, monitor the patient's ECG very well. Then you give calcium gluconate. Calcium gluconate can be given to prevent what? Prevent cardiac arrhythmias. Okay, it can be given to prevent cardiac arrhythmias. So that is something that you do in hypokalemia.
Hey,
Okay.
boss, Aki.
Yes.
Please, I'm sorry, but my network went off for a brief moment. Can you please take it again? I don't know where you are right now. Are we at the IV fluids?
No.
Then I'm lost. I'm
So
sorry.
you missed the whole thing.
Think so. I'm sorry.
It's not easy. All right. So I said that the interventions, you give IV fluids, you give IV fluids to replace the lost water. You know, we are going to urinate a lot, so you are going to be dehydrated. So even under that, you must monitor for signs of dehydration as well. Weak and steady pulse, hypotension, tachycardia. You must monitor for all those stuffs, okay, under DKA. So you must give IV fluids to replace it. Then you administer IV regular insulin. Insulin is to ensure that the patient's glucose level drops to normal range, okay? But because you can cause hypoglycemia, once you start the regular insulin, check the patient glucose level every 1 hour to prevent hypoglycemia. Check the sugar level every 1 hour. The moment you start suspecting hypoglycemia, that is, sugar level starts dropping, okay, below normal, then you should switch from the regular insulin to what? 5% dextrose in water. Okay, 5% dextrose in water. That is what you must switch to. You give 5% dextrose in water. Okay. Then what's next? You must monitor for arterial blood gases. Okay, arterial blood gas like metabolic acidosis because of what? Because of the ketones. Okay, metabolic acidosis. Then I said that once you start giving insulin, insulin has a way of shifting potassium. Insulin has a way of shifting potassium from the blood into the cells. So the moment you start giving insulin, you have to be on the lookout for what? Hypokalemia. If there's hypokalemia, then what do? You stop the insulin, you initiate cardiac monitoring, you monitor the patient's ECG very well, and you give calcium gluconate. Calcium gluconate is given to stabilize the heart and prevent what? Cardiac arrhythmias. Okay, so that is something that we should know, right? That is something that we should know. Okay.
And then
Very
let's
good.
in this.
Yes.
So I think because of that, because insulin wastes potassium, on the DK protocol, there is automatic. There is I think the first 1 hour it starts with the IV fluid, 1 liter normal saline, and then I think after by the second hour you automatically start KCL infusion. So you have 2 large IV balls, one on the left, one on the right. You put your insulin, you start your insulin at one side, you start your potassium and your KCL infusion too at the other side, and then you put the patient on a cardiac monitor. Well, that is how we do it in the emergency.
Okay,
Thank
that is
you.
fine. That is fine. Okay, thanks for that. Okay, that is a good addition. It's a good addition. Okay, all right.
Okay, I wanted to ask a question about
Okay, you can.
the 5% dextrose in water. So the patient is taking it orally. So what if the patient is unconscious? Do we have to pass it? There's still 5%, give it as IV.
The 5% dextrose in water. Yes, but then if you want to increase sugar level and then the patient is unconscious, what do? We give glucagon. We give IM glucagon. Okay. You give IM glucagon. Yes. Anytime a patient is, I think this question we come across it, right? Anytime a patient is unconscious and is in hypoglycemia, it means you can't take anything by mouth. Okay. It can't take anything by mouth. So you just give them what? What do you call it? IM glucagon. It will increase the sugar level. Okay. All right. Thank you. Any other question, please? Hey, can we finish this topic?
Please, senior, give me this. Please, I thought with the correction of hypoglycemia, we normally give the 50-50. After the 50-50, then we give the 5% dextrose as maintenance dose.
Yeah. So
like,
what I'm saying, okay, you finish. You finish.
So it's like I'm lost. I know that when a patient goes into hypoglycemia, we give 50, and after the 50-50, we keep quiet. We give 5% dextrose as maintenance dose.
Yeah. So the 50% usually comes in severe hypoglycemia. Okay. That is a severe one. And then this 5% dextrose in water, we don't wait for the patients to go into severe hypoglycemia. The moment we start suspecting that the glucose level has started dropping, okay, I think there's even a value for that. Okay. The moment we start suspecting that the patient's glucose level have started dropping below, I think, the 250, then we can switch the 5% dextrose in water. Okay. Because when you give, when you give the 50% dextrose, it's going to increase the sugar level very, very, too much. Okay. And even the hypoglycemia, first of all, if a patient comes to your ward with hypoglycemia, do you know the first thing we do is to give oral carbohydrates like sugar? Okay. So we give them drink like Coca-Cola or anything that contains sugar. Okay. We give them those drugs so that it can do what? It can help the patient. We give them those drinks, the sugary drinks, to increase the patient's sugar level a bit. Okay. It is only in severe instances where the patient become very, very unconscious. That is where we can give the 50% dextrose. The 50% dextrose. Okay. But then other than that, usually we give the 5%, especially the DKA. Okay. Yes.
Hello, Nessa, give me this.
Yes.
Yeah, I'm just adding up. So from what our sister was saying, I realized in Ghana we were doing the 50-50 thing.
Okay.
Especially when we find somebody in hypo, maybe around 3 and below, we quickly run to do the 50-50. But up here abroad, what they normally do is like just like what you were saying, they start with the oral glucose. So maybe you take a blood level, you check your BM or something, and realize that your patient is 3.9 or 3.5. The first option is to go for your oral glucose. It's already prepared in tiny bottles. You squeeze it into the patient's mouth, and you allow the patient to drink that. After which you test the blood sugar again. Most of the time it comes up. You only start your IV glucose percentages when you have very low blood sugar levels. And even that, they don't even start with the 50% straight away. We have 20% before we have the 50%. So they will even start from a lower dose. I realize it's Ghana that we run into 50-50, doing 50-50. They don't do those things normally here. And
Yes.
then
So
we maintain it with the
uh,
5% dextrose.
very good.
Thank
Thank
you.
you. So please
Hi,
don't take
Boss
out.
Akim.
Yes. Hello.
Please, I
Yeah.
wanted to know. I'm a bit confused. Is the DK, does it only pertains to hyperglycemia, or we have DK which comes with hypoglycemia too?
Oh, no. Usually hypoglycemia, DK is with hyperglycemia. Okay, that is when you are not getting the insulin. You are insulin dependent. The body does not produce insulin, so there's increase in glucose in your blood. Okay, so that is hyperglycemia. The hypoglycemia will come in later when you start
After
giving the
managing, yes. Okay, when
exactly
you started giving the normal saline, okay, that's fine.
exactly.
Okay, thank you. I get it now.
Yeah, so please let's not really carry the Ghana nursing type. Okay, let's follow the Enclaves
Please, I
type.
have a question.
We can get the right answers. Okay, yes, yeah, please ask your question. Please ask your
Please,
question.
the 5% dextrose in water. Are there situations? I'm saying that. Can you hear me? Hello.
Yeah, I can hear you.
I'm asking that the 5% dextrose in water. Are there situations whereby instead of giving it orally, you can give it IV?
Ivy. Yes,
As
yes.
like a maintenance, yes, IV maintenance instead of the oral.
Oh yes, you can. You can give it with what we call the aqua.
Okay.
Okay, when we hear the water is it can we have
Okay.
we have sterile water or sterile aqua. So you just mix it with that and give it. Okay.
Yeah.
Can I come in small?
Yes, come in.
In Ghana here, the protocol for managing DKA, you give the normal saline 1 liter 30 minutes after, then you give another 1 liter 1 hour after. So you give a normal saline 1 liter for 30 minutes, first 30 minutes, then 1 liter for the next 1 hour, then another 1 liter for 4 hours, then subsequently you give 1 liter. It's after that when you give the insulin by IV and IM. That's the sliding scale. So when you finish and monitor the glucose and you see that it's low, that's when you give the 5% dextrose 1 liter every 6 hours to prevent subsequent hypoglycemia. That one is different from somebody who came with hypoglycemia. So we shouldn't confuse with the two. This one, you don't want the hypoglycemia to get into severity. So because you are giving the insulin, you know definitely the client will end up losing more glucose. So you are trying to balance the two. So that is how we
Senior
do
Kim,
it.
please, can you please go over? We want the protocol for NCLEX. All of us here, we are aiming to pass NCLEX, not in Ghana. So please, can you give us the protocol for the NCLEX and
That
then
was what I was going to say.
the 5% dextrose in water? When we were talking about, I thought it's IV. I just realized someone was saying the patient will drink it. So I'm lost. So please, can you go over that one and then give us the protocol so that when we meet it in the near future, we can.
All right. So first of all, you begin with IV fluid. Okay, please let's stick to what we are learning for the NCLEX. Okay. You know,
Okay.
Yes, we have a lot of management when it comes to this DKE because of how common the condition is, how common diabetes is. Okay. But for the English, let's just go with this. First of all, usually we give the normal saline. Okay. We give the normal saline usually first. Okay. Then we now begin the regular insulin. Now, after the regular insulin has been started, because patient can run into hypoglycemia, the moment we start getting a sugar level coming below coming below 13, okay, now around let's say 12 or 11, we give the 5% dextrose in water. Usually it's IV, okay. Usually it is IV. We just withdraw it with let me see, aqua or sterile solution, okay, and we give it IV to balance the hypoglycemia that is impending, okay. So that is all what we do for DKA management. There's nothing, confusing over here. Give your IV fluid. You don't give insulin first. The reason is that when you give, this patient, I didn't want to go into this, but because it can lead to a lot of confusion. This patient, it's like they have hypokalemia and hyperkalemia at the same time. Even before you start the insulin, they have hypokalemia and hyperkalemia at the same time because they are urinating a lot. So because they are urinating a lot, they are excreting more potassium. So they are already in hypokalemia. Okay. But then again, they are in hyperkalemia because they have acid, the acidosis, which we call a pseudo hyperkalemia. Okay, that is a false hyperkalemia. Okay, so usually we don't give the insulin first. We give the IV fluid so that the patient will have a balanced electrolyte. When you place fluid, patient get a balance of, we have what we call fluid and electrolyte balance. Okay, the moment the patient is running low in fluid and you balance it, the electrolyte becomes normal. So usually we begin with the IV fluid to balance the potassium level. Then later we can start the regular insulin. So as and when we are giving the regular insulin, then that is when I said you should monitor for what? A rebound hypokalemia, because insulin can shift potassium from the blood into the cells. So please, let's note, don't begin insulin first. Begin with the IV fluid. When you begin with the IV fluid, you continue with the regular insulin. The moment you start suspecting a low glucose level, start giving the 5% dextrose in water. Okay, give the 5% dextrose in water, and then observe for what? Rebound hypokalemia. That is it. Okay, that is it.
Excuse me, Boxaki.
Yes.
The insulin. Is it how are you going to be giving it? Are you going to giving it as to when the blood level goes up, or is going to be a constant insulin on the patient?
Yes, like a constant insulin on the
It's
patient.
going to be an insulin pump.
Yes, something like that.
Okay.
Yes.
Okay.
Yes.
Fine. Thank you.
Yes. You're welcome.
Please, I know we normally do 0.1 per kg. So it's a fixed rate on the patient. You run it on a syringe drive.
Yes, on a pump. Yeah, to prevent hypoglycemia, you must use a pump. Okay. All right. So that is it. Some of these things, especially when we are talking about this
Let me just
American.
clarify something small. Let me just say it the way I understand. So while the insulin is running, you check the glucose every hour. If it drops below 11, you give 5% dextrose or the 5% oral.
Exactly. Yes. Exactly.
Okay, good. So whilst you are doing this, that is when you do the ABGs. If it is hypokalemia, you give the KCL or what?
If it's hypokalemia,
or you start the KCL anyways.
This is what I mean. What you start the KCL when there's hypokalemia, but then obviously insulin will cause hypokalemia, but it's obvious. That is why my sister said that please, we shouldn't bring practice into the test. Okay, when you are practicing, it's different from when you are studying. Okay, usually the practice has some kind of difference. Okay, my sister said that because the insulin will cause hypokalemia in the long run, you pair it with the insulin right away. Okay, but then in book, please know that the KCL counts in only when there's hypokalemia. Just know that. Okay, you begin to give the KCL when there is hypokalemia. You can't give KCL if there's no hypokalemia. You
Okay,
can't.
okay.
Yeah.
That's
So
after
just
the
take it as
ABGs. Is there only the ABGs that will give you the low potassium hypokalemia?
ABG deals with metabolic acidosis. Okay, the hypokalemia, you must monitor it
You
once
do
you start giving
VBG.
the once you
What do
give
you
the
do to get the hypokalemia? VBG.
VBG. Yes, you can do VBG, venous blood gas.
Oh, okay. Okay. I thought ABGs also do that. Okay. Okay.
All right.
You
Thank you.
can, but mostly it's VBG. We normally do the VBG.
Okay. VBG. Okay. Okay. Thank you.
Very good. Very good. Today, the class is very, very interactive because this condition is common. All right. So that is it. Okay. That is what we should just know for our English. Okay. Once we travel to US and we are practicing, you understand it more. Okay. Because it becomes part of our, in book, sometimes the way they arrange the things, or sometimes the way we read from the book is a bit different. Okay. But please, the KCL there, please let's note. You give the KCL when there's hypokalemia. Okay. So please let's note. But then obviously, once you start insulin, there will be hypokalemia. All right. That is fine. So we are done with DKE. Okay. Today, can we complete the topics? This topic. All right. Let's move on. Okay. Because I want us to talk about the insulin as well. All right. So we have the next one. We have HHNS. Okay. HHNS. I'm sure this one too, you know about it. This one too is a complication of type 2 diabetes. Okay. The hyperosmolar hyperglycemic non-ketotic syndrome. Okay, HHNS. Okay. This one too is a complication of what? Type 2 diabetes. And with this one, the patient is producing insulin. Okay, because in type 2, there's insulin production. But
Please,
there's just
hypo. Can you just tell us
it's
the
on my screen. You can see my screen.
hypo?
Please, it's on my screen. Can you see my screen?
Yes, I can, but I can't seem to see what the meaning of the hyper HHNS is.
Oh, can't you see, please? Or is she the only person? The definition there.
I can see. No, I can see.
we
I
can
can
see.
see.
Hyperosmolar
Appreciate.
hyperglycemic.
I appreciate. Okay, it's fine.
Hyperosmolar.
It's fine. It's okay. It's okay. Thank you. Thank you so much.
So it's hyperosmolar hyperglycemic non-ketotic syndrome. Okay, hyperosmolar hyperglycemic non-ketotic syndrome, HHNS. Okay, and I'm saying that this one is a complication of type 2 diabetes. Okay, it's a complication of type 2 diabetes. Here, there's no ketosis. Please take note. In this, so we have non-ketotic. Okay, here there's no ketosis because the patient is producing the insulin. Just that to some extent, the insulin is meeting resistance. Okay, to some extent, the insulin is meeting resistance. So the insulin is not being effective, just as what we learn in type 2 diabetes. Okay, so that is something you should just know. So HHNS is a serious complication of type 2 diabetes characterized by severe hyperglycemia, dehydration, and hyperosmolarity without significant ketosis. Okay, all right. So here to the symptoms. They have severe hyperglycemia, and then they can have a glucose level of 600. Here to please, let's convert fast. 600 into millimole per liter.
Divided by 18.
Yes. How did we get?
So keep it this, please. It's time. Some of us are going to work. I can't miss the rest. So
Please, we got 33.3.
33 point. Let's just add some few minutes, okay? Let's see if we can end at 6:30. Okay. So that we can.
to go to work.
Yeah, you listen to the recording later. Don't worry. Okay. So the answer is 33, right? 0.3. Very good. So severe hyperglycemia. So in HHNS, they have a sugar level around 600 milligram per deciliter or 33.3 millimole per liter. So if a patient comes to your ward with type 2 diabetes, and then the patient starts recording sugar level of around 600 milligram per deciliter or 33.3 millimole per liter, start thinking of what? HHNS. Okay, very good. Then you can have dehydration because here there is hyperosmolar. There is increase in osmolarity. Okay, on osmosis. Okay, so the water just shifts out. Okay, So there's going to be dehydration, there's going to be dry mouth, orthostatic hypotension, decreased urine output. Please note, the decreased urine output does not start in the initial one. It comes later when there is dehydration. So don't get confused, okay? At the initial stages, you are urinating plenty because of the glucose level. So when you urinate plenty, your water level will go down. Then you become dehydrated. That is when the urine output will become low. So let's take note, okay? There can be altered mental status. So there can be confusion, dehydration, and there can be coma as well, okay, due to increase in your glucose level. Now, when there is coma, when there is altered mental status, we can't go about leaving what? Seizures, okay? There will be seizures as well, okay, because there is disorientations, there is changes in your mental status, okay? Then we can have hemiparalysis, that is paralysis. Of course, diabetes can lead to what? Hypertension. And then later we can get what? Paralysis, okay, when there is stroke. Then visual disturbance, I think I've said it earlier on about retinopathy, okay. Then we can get cardiovascular instability, hypotension, tachycardia, and arrhythmias, okay. When you are dehydrated, when you are urinating plenty, what occurs? There's decrease in what? Intravascular volume, so there's going to be hypotension. Down, there will be a compensatory mechanism of the heart, then we get tachycardia, then later it leads to what? Silent tachycardia, atrial fibrillation. So these are some of the signs and symptoms of what? But never forget the 600 milligram per deciliter or 33.3 millimole per liter for HHNS, okay. So how do you diagnose it? Here too, we can do the blood BUN nitrogen test, creatinine and osmolality test, okay. So you take blood sample to, and the urine sample as well to the lab to check for the blood glucose levels. You check for the electrolyte levels, okay, and then you check for blood urine nitrogen levels as well as creatinine, okay. Then you do urine analysis. So urine specific gravity will also be tested, okay. But then please note here, because it's a complication, okay, it's a complication. So at this stage, patient is dehydrated, okay. So they are not bringing more water out. So they are going to get a high urine specific gravity, okay, a high urine specific gravity, because at this stage it's a complication. They are already dehydrated, okay. Very good. So let's take note, a high urine specific gravity. That will be the pH of the urine, okay. And then there will be no ketones. Please take note, there will be no ketones in the urine. In HHNS, there's going to be no ketones in the urine. No ketones in the urine. Okay. Then we can do chest X-ray, we can do CT scan, we can do MRI to rule out other conditions that might result from what? That might result from HHNS. Okay, very good. So that is it. So here to the treatment is the same. Okay, treatment is still the same because you are dehydrated. Okay, so you place the fluid by giving acetonic or Ringer's lactate. Then you also give insulin because of the high sugar level. Okay, you give insulin as well to control the sugar level. Then you give electrolyte replacement like potassium, sodium, magnesium to correct electrolyte imbalances. When you urinate plenty, you lose potassium. Okay, so you must replace the potassium to correct the electrolyte imbalances. Then you monitor closely the patient's vital signs, the blood glucose, and the electrolytes. Then you can give oxygen, antipyretics, and anticonvulsants. If there's seizures, if there is, respiratory difficulties, you can give what? Oxygen therapy to help with the situation. Okay. All right. So that is that for HHNS. The complication, you can get cerebral edema. The reason why we get cerebral edema is because we have to replace the fluid. Okay. So when you replace the fluid, sometimes the fluid can, become plenty and it can shift to what? It can shift to the brains. Okay. Too much of what? Too much of fluid can shift into the brain. Okay. So this can cause seizures as well. And then let's not forget, actually, when you have hyperglycemia, okay, when there's too much glucose, you can even get seizures. Okay. That is another thing that we should also know. There can be cardiovascular instability like hypotension, tachycardia, arrhythmias that can lead to cardiac arrest. Then if there's cardiac arrest or cardiovascular instability, we can't forget the kidney. I think I've been saying this throughout our presentation. You can't forget the kidney, okay? So there'll be acute kidney injury, chronic kidney disease, that can occur due to dehydration, hyperglycemia, and hyperosmolarity. Okay, so that is it. All right, please, are you okay for HHNS? Let's talk about the insulin administrations, and then maybe we end the class. Are we okay, or we are tired? Okay. Hello.
We are not tired.
We are not tired though.
Oh, good. All right. So this one is very, very important. What we are going to discuss. Please open your eyes and open your ears. If you are tired, wash your face now. Okay. Because this one is very, very important. It is very, very, very important. Okay. This one is very, very, very important. All right. So we have types of insulin we give to patients with diabetes. Okay. We have types of insulin we give to patients with diabetes. Right. So we can give them what? The rapid acting, the long acting, the regular, and the intermediate. That is the NPH. Now, let's go straight to the point. So each of them has their onset, their peak, and then their duration. So let's begin the rapid acting. Example of rapid acting is the Lispro and then the Aspart. Okay, please let's note this down very, very well. Okay, it's very, very important. So the types, we have the rapid, long acting, regular, and intermediate. So let's begin the rapid acting. Example of them is the Lispro and then the Aspart. So once you give a rapid acting insulin, the onset is 15 minutes. Okay, the onset is 15 minutes. The onset is 15 minutes. Once you give it, they have the onset at 15 minutes time. Okay, but the peak is 30 minutes to 3 hours. Okay, they peak around 30 minutes to 3 hours. Please note that they peak around 30 minutes to 3 hours. Okay, and then the duration is 3 to 5 hours. So rapid acting, onset is 15 minutes, peak is 30 minutes to 3 hours, and duration is 3 to 5 hours. Okay, I will say something about the peak later. Okay, don't worry about the peak later. All right. Then the long acting, onset is 2 to 4 hours. Okay, for them, because it's a long acting, they don't have any peak. They don't have any peak, and then the duration is also 24 hours. Okay, their duration is also 24 hours. Their duration is also 24 hours. Then we have the regular or short acting. The regular or short acting. So them, their onset is 30 minutes. Their peak is 2 to 4 hours. And then duration is 5 to 12 hours. Okay, duration is 5 to 12 hours. And then let's go to the intermediate. The intermediate onset is 1 to 2 hours. Peak is 4 to 12 hours. Then duration is 12 to 18 hours. Okay, so as you see on my screen, it is as it is. Now, on the NCLEX, and usually they ask questions, forget about the rest. Usually they ask questions on the peak alone. Usually they ask questions on the peak alone because it is during the peak time that the patients run into hypoglycemia. Once again, never forget this as you study for the NCLEX. NCLEX are exams of safety. So always they bring questions that will let you put the patient's safety intact. Okay, very good. So they ask questions about patient safety most of the times. So this question, this insulin thing, what is really focused on is their peak level. Each of them, their peak level. Okay, because it's at the peak time that the patient starts running into hypoglycemia. That is when the drug begins to peak. Now, let's say on my time now, it is 6:25. Okay, on my time now is 6:25. So you give a patient rapid acting insulin. It means that the time you start checking for hypoglycemia should be the next 30 minutes. Let's take note. You give the patient the drug, you give the patient rapid acting at 6:25. The next time you must monitor for the glucose level should be 30 minutes time. That is when the patient starts running into hypoglycemia. Okay, so you check the sugar level very well at 6:55 when the patient starts running towards hypoglycemia. Okay, so let's take note of that. Okay, and then because of that, for example, I'm still using the rapid acting as an example. Okay, when you are going to give patient a rapid acting insulin, never forget, because the patient starts peaking, the drug starts peaking in 30 minutes time. Don't make sure that once you give it within the first, and then let's not forget the onset. Within the first 15 minutes, the drug will start working. So they must eat within the first 15 minutes. Okay. So let's take note. The peak is the time the patient starts running to hypoglycemia. The onset is when, the patient should be eating by that time. Because after 15 minutes time, the drug has started working. It's like if it is a flight, it has taken off. Okay. So if you're going to give rapid acting to a patient and then you give it within 15 minutes time, they should eat to prevent hypoglycemia in the next 30 minutes time. Okay, well, let's say the next 30 minutes. Okay, please. So let's take note. The peak level is the time the patient starts running to hypoglycemia. And most of the times, that is what the NCLEX will ask you. When should you monitor for hypoglycemia? When does the patient run to hypoglycemia? Okay, very good. With regular or short acting insulin, you must give what? You must give their insulin. You must check for what? Hypoglycemia at 2 hours time. Okay. And then always make sure that when you give this drug, the patient must eat within 30 minutes time, because that is when the drug will start working. Okay. That is when the drug will start working. So that is that for insulin administrations. Okay. We have additional this thing over here. Okay. I think this is our last slide. Okay.
Senior, give me this.
Yes.
Please, when do we administer rapid and when do we administer regular? It seems both of them, the consistency of the drug is the same. Both of them are clear like water. So I want to know when you administer the regular and then when we administer the rapid.
Okay, those ones. So rapid insulin, but then all these things mostly depends on what do you call it? The doctor's prescription. Okay. Usually the doctor will prescribe the kind of insulin to be given at a point in time. Okay, because they all act to reduce your sugar level. Okay, one is not superior over the other. Okay. But then just that, if you want to really reduce sugar level very fast, you can give the rapid acting, because that one is rapid, it's fast. Okay, it can reduce the sugar level as fast as compared to the long acting and then the regular. Okay, so you can give the rapid acting insulin. That one acts very, very fast, especially when there's a severe hyperglycemia and you want to reduce the sugar level very fast. You can give that one. Okay, but then in all of them, it depends on what the doctor will prescribe. Especially, we all know that IV, in all of the insulin that we did, okay, the types of them, the only one that we can be giving IV is regular insulin. Okay, the only one that can be given IV is regular insulin. And then we all know that drugs given IV works faster than drugs given, let's say, IM. Okay, good. So if, for example, there's a serious hyperglycemia and you want to achieve a fast reduction in the glucose level, that is why in DKA we even give the regular insulin. Okay, because it's a life-threatening situation. Why don't we give the IV one to reduce the sugar level as fast as possible when the patient will come back to what? A hemodynamic state. Okay. So that is what you should just know about the drugs. Okay. All right. All right. So let's know this about insulin. Okay. Once you open a package, the new expiry date is 30 minutes, irrespective of the long acting expiring date. So what this means is that, for example, you picked an insulin bottle from the patient's drugs, okay, to give, or from anywhere to give, okay, or from the pharmacy to be given to a patient. Please note that once you start using the insulin, the expiring date now changes to 30 days. So even if on the drug you see 2027 March, it doesn't stand again. The moment you open a new package or you open the drug, the expiry date is now 30 days. Okay, irrespective of the manufacturer's the manufacturer's expiring date, the one on the box, irrespective. So let's take note. Okay, on open packages should be refrigerated, but once opened, refrigeration is optional. Please note, if an insulin is not opened, you can keep it inside the fridge. But once it has been opened, you must refrigerate it. And then, I'm sorry. If it's not open there, refrigerate it. That one is a must. If it is not open, it's a must. But then once you open it, you can keep it at the patient bedside at room temperature, okay? Or decide to refrigerate it. It's optional, okay? So let's take note. Then the only insulin that can be given IV is regular insulin. Okay, the only insulin that can be given IV is regular insulin. And then you can't mix long-acting insulin with any other insulin. Let's take note. You can't mix long-acting insulin with any other insulin. Okay, you can't mix long-acting insulin to any other insulin. And then you can mix regular and NPH, but then always you withdraw what? This one I didn't put on a slide, so please note. Always you withdraw the regular first before the intermediate. Okay, always withdraw the regular first before the intermediate. So that is that about insulins. Okay, that is that about insulins. And then that brings us to the end of our class.
Can I say something?
Yes,
They
you can
use
say.
the acronym RN. RN means regular and intermediate. So if
NPH,
you
exactly.
so you when once you remember RN, then you know that you withdraw the regular before you withdraw the intermediate. So
Very
that
good.
was the sequence.
Please, can I see the last slide?
You said what?
Can I see the last slide?
The last slide.
Yeah, the one that talked about the mixing and the
Okay,
packaging.
let me show that one. Okay, so it's here. All right.
Okay,
So
thank you.
this brings us to the end of endocrine system, DM, and an endocrine system. Okay.